So the key issue I would like to bring out there is that diabetes patient is a must, and patient education is a must. It should be one of the fundamentals of diabetes care, and this is the reason. In chronic care, we would like as much as possible to put the patient in command of their condition. We would like to empower them. The success of care is as much or even more about the patient, what the patient does, than what even the healthcare worker does. So we would like to drive towards autonomy. A patient who is activated, they know exactly what to do and when to do it, and they take charge and do it themselves, so that they even limit the amount of time they need to spend at the healthcare facility. And this goes with health education.
That's true.
So diabetes health education is fundamental to create this type of patient that we need. And this should cover areas of, first, they need to know about the disease. What does it involve? And what should they expect? They should know about being a chronic disease. They should know what is in it for me and what should I expect over the years, so that they deal with that. Two, they need to know that there are certain things that they can do to have a good quality of life. Because it's possible to have a good quality of life even with a chronic disease.
It is.
So they need to be empowered on diet, physical activity, self-care, and then some habits that they need to drop if they were doing them, but also the social implications of their illness. That is one thing that people don't take importantly. How does society view diabetes? And how does society view the lifestyles associated, the diet, the physical activity? And how do they fit their lifestyle to create a balance in which they do not feel uncomfortable in society? So that empowerment comes with health education.
That's true.
And I'll take it a notch higher. In addition to the health education, there's something called motivational coaching. So health education empowers them with the information, but motivational coaching takes them through the challenges they meet and the opportunities they have in their environment to address their situation. So you get an experienced coach. Sometimes it's a diabetes patient, sometimes it's a person who is knowledgeable about diabetes. They ask them, what are some of the things in your environment that can support your care? Maybe I have a cousin so-and-so, maybe I have an auntie here who knows about these things. And then it helps them to think about some of these things. When you look at diet, what foods do you have? How can we, what other opportunities for food do you have, and how can we get the best out of what you have? So that coaching takes them down into their physical environment, so that the things which you tell them to do, they can relate them to what is available in their households. So that is an additional issue.
That's actually very important. I've actually realized as they're learning more, the patients tell me what they think they should do. And most times they do have an idea. So it's just important to empower them and tell them, you know what, you're actually on the right track. Just keep telling me. And then you get to hear what misinformation they have. And you get to hear what they're doing right. So you emphasize and tell them, okay, this is good, but let's try to stay away from
this one.
Exactly. So they actually do have an idea, which is very good.
So I like the point you raised of you emphasize the good things they are doing. And then you piggyback on that to suppress the not so good things they are doing.
Exactly. It's very important. So the next question we have is, how has your work in diabetes evolved over the years? And what else do you have in store?
So when we started this work in diabetes, we were dealing with basic issues. There was no information on prevalence at national level. The health systems, we didn't know what was going on. So we did mostly formative studies. I remember one of the first studies I did as part of my PhD. It may look simple, but it was very important, is the prevalence of diabetes.
Type 2.
I was mainly focusing on type 2 diabetes, but in a rural setting. Yeah. So the question was, do we have diabetes sufferers in the rural areas? Yeah. Contrary to the thinking that type 2 diabetes is mostly for rich people, it's an urban disease. And we found that actually there was substantial prevalence in this community. Yeah. We found in Iganga a prevalence of 7% in people aged 35 years and above.
Wow, that's a very high
The National
prevalence.
Risk Factor Survey found a diabetes prevalence of just 1.4%.
Yeah, I've seen that number.
But in this community, we found when you look, because for the national survey looks at people from 18 years and above. Yeah. Here we focused on 35-year-olds and above. They are older, but even still, the prevalence was quite high, 7.4%.
That's very high.
So then we also looked at some risk factors, which we found to be fairly prevalent in the community. Some of them were low, but others were there in sizable numbers. Yeah. So they were mostly trying to understand the burden of the problem. Yeah. And then we looked at some of the tests, the primary care tests. And we found in one of those studies that the agreement between fasting plasma glucose and hemoglobin A1C is low, is relatively low. Yeah. I'm referring to rapid tests, not lab-based tests. Yeah. But we are interested in rapid tests because we want them to be applied at primary care level. Yeah. We found a low agreement, and this raised several issues about what type of tests should we use in Uganda at primary care level. So now we are following it up with more rigorous studies to find out, and we shall make a recommendation on that. Then we did a social assessment. What do people think about lifestyle diseases? And this is where we found another big disaster. Yeah. The awareness is quite low. Okay, almost every household has a relative who has had diabetes. Yeah. But when you go to the depth about the causes, the symptoms, what to do, the awareness is low. Very low. The people were concerned about the disease, but when you told them about the lifestyles, they developed cold feet. Yeah. Because the preventive lifestyles and indeed treatments for diabetes, communities view them as a not so good lifestyle. Yeah. So when you tell someone to eat more veggies, when you tell them to reduce refined carbohydrates, red meat, they look at you and they say, but this is life. Yeah. So there's a lot that needs to be done to change people's mindsets about, these days we talk about what constitutes a good life. Yeah. People don't know that. So we need a cultural change. Yeah. We found that, especially for type 2 diabetes, weight, extreme body weight is an issue. Yeah. But in the communities there, weight, the bigger the person,
the healthier.
The healthier. They view it as healthier. Yeah. Somebody has gained. Yeah. And they associate it with money. Yeah, and when you lose a lot of weight, the communities say you have HIV/AIDS, you have problems, or you fail to pay back a bank loan. Wow. So that's what they think. So then not like reducing the frying of food. They say, how will you eat that? Reducing salt in food, that's mainly for cardiovascular diseases. They say, what are you talking about? So that's what we found down there. Yeah. So we produced a paper which is called Change is associated with sacrificing a good life. Yeah. So the changes you tell them, they associate them with sacrifice. They are viewed as sacrificing a good life. That's true. We got an old man some old people there in Iganga who said, if a 50-year-old man in Iganga is seen doing a drill or an exercise, they might call the ambulance to Butabika. because it is not expected. Putting on shorts and going out for recreational activities. Some of them say that playing is for children. They view playing around in the football field as for children. So there's a big thing about the mindset change. So after these basic studies, we move to the next level. We are now doing testing and intervention. Like what package of activities can improve prevention and care for type 2 diabetes. So what we did from these formative studies, we formed an intervention. It includes diagnosis, improving diagnosis, clinical care guidelines, training healthcare workers. It includes health education, so we developed a simple manual. We developed a very short health education brief that is pictorial in 2 languages, English and Lusoga. We developed those, then we developed guidelines for care companions, and then we formed diabetes patients into peer groups at the community level. So we are testing it. That trial started in 2016. It's due to end in December, and then we shall analyze and come up with new findings. So now we are more on the solution side. Previously we were more on the problem side, but now we are more on the solution side. Now, in terms of the future, diabetes, especially type 2 diabetes, we know occurs over years of risk. That some of that risk, we believe, is carried from childhood. Indeed, some children who don't necessarily develop type 1 diabetes develop what is called insulin resistance as early as adolescence. Then we have some people who get delayed type 1 diabetes. That is one thing which people don't realize, that type 1 diabetes can come in the 30s. But the problems, some of the issues that tip it over could be insulin resistance. So when the two mix, then they get a very dramatic mix of type 1 and type 2 diabetes in middle age. So what we are thinking now is that we want to track lifestyle diseases earlier from adolescence. So we are now in initial discussions, conversations on how to set up a long-term trial in schools. And the reason for that is that I was part of a study that was done by a pediatrician who happens to be my wife. And it was done in 4 secondary schools in the Wakiso district, which is a peri-urban district. And in those schools, she selected 4 schools, one which is a high-income school, and then the other one is a lower-income school, and then in between there. I'll not mention the schools. And there were girls' schools, boarding schools, and they found actually a substantial prevalence of prediabetes in these schools. A prevalence of 6%.
That is high.
Among people aged 12 to 19 years.
Wow.
6%.
That is very high.
And in the high income school, the prevalence was actually 9.8%. While in the lowest income school, it was about 2 point something percent. So quite a big gradient.
That is a very big difference.
And the prevalence is higher in the younger age group, that is 12 to 14, compared to the older adolescents. This could be related to adolescence, the changes that occur in adolescence.
That's true.
But we would like to see what happens to some of these children through the life cycle. Can we predict over their life cycle who is likely to develop type 2 diabetes? Is there things that occur in adolescence that can tell us risk in the future? So we want to set up now a longer term study. We think schools are a very good environment because many schools require a clinical examination before, especially boarding schools.
Yeah.
So we can take opportunity of that. We offer the checkups, and then we track these adolescents over 6 years, and if 6 to 10 years. If they go to university, we can still follow them up, and we see if we can get new markers that can tell us risk, so that we are able to deal with the risk early.
Yeah.
And the other thing is there's a lot that needs to be done in school health programs, especially in boarding schools. We found the lifestyles of those youngsters, they are unguided. Physical activity has reduced in schools so much. Some of the children who need physical activity most, they tend to dodge it. Either they pretend to be sick, so they don't go to the garden. They have one garden day a week in some of those schools. I'll not mention them. Then in some of the schools, we found they carry a lot of edibles. They call them grab.
They grab
a lot. And
they're mostly sugar-based.
Sugar-based. They eat as soon as the lights go off. They start eating
in the darkness.
In the darkness. They told us they do a mixture of sugar with chocolate and powdered milk, and they call it choco milk. And they lick that from when they sleep at 10 o'clock to about 1 o'clock. They are licking sugar and eating all sorts of things.
And this is just before bed, when you shouldn't
just
actually
before
be
bed.
eating these things.
Yeah. So we think some of those things are driving insulin resistance in these youngsters. So we need to now think of the longer term. Now that we are dealing with the interventions. Now we need to think about how to tackle the problem over the lifestyle.
Yeah.
But also we need to support, let's say, type 1 diabetes patients over the lifestyle.
Yeah.
I mean the lifespan, so that we see what kind of things do they need at different levels of their lifespan.
Yeah.
So we need to look more long term, and that's where we are moving.
Oh, wow, that's amazing.
Yeah.
I read recently that mothers who have gestational diabetes, their children have a higher chance of getting insulin resistance and developing type 2 diabetes later in life.
Yeah.
So maybe that might also be a contributing factor.
Yes, so those are things which need to be studied in our context here, because there's the link between gestational diabetes and development of diabetes later in life has been established.
Yeah.
Then the link between insulin resistance for the baby, the babies of mothers, has also been established. But these studies have been done in developed countries. We need to do them here.
That is important.
There's also the new theory that malnutrition occurring in the critical stages of life as of a child is associated with a high likelihood of developing insulin resistance and type 2 diabetes later in life.
Yeah.
And the link is through a genotype genes that developed because our forefathers were hunters and gatherers.
Yeah.
So the insulin would be produced when they've caught an animal. So they didn't need to produce a lot of insulin, and the body was tuned to that type. Insulin
and their diet was very different from how it is now.
Yes.
Yeah.
So the insulin would be released in pulses when you've eaten, and that's how the body has evolved. But now we eat all the time, so we have
the wrong things.
Yes. So then people have high levels of circulating insulin, and then the body reacts in an adverse way, which creates insulin resistance.
Yeah.
So we need in the future to look at how is undernutrition affecting
the prevalence of
diabetes and other related lifestyle diseases.
Wow, that's an interesting topic.
Yeah.
Yeah. I've actually wanted to mention with diabetics are so afraid of complications.
Yes.
But when it comes to type 1 diabetes, complications take so long to occur.
Yes.
If you're taking good care of yourself.
Yes.
But it can also happen very quickly, very rapidly if your care is just very bad.
Yeah.
So I've actually known a few people who have been diabetic type 1 for 2 years or 4 years, and already they have neuropathy, severe complications. They have serious neuropathy. I don't know why it's the first thing they're both facing, but I've realized and this other gentleman that I met recently on a just random bus journey, I met this gentleman and we were both diabetic. It was very interesting. So he sat down and told me in that particular moment he's traveling a very long distance.
Yes.
He did not carry insulin with him. He had left it in Bara, in Kavali. He had left it 3 days ago. So he was not taking medication.
He's not taking any medication?
Nothing.
Yes.
He had been drinking that night. He said he was drinking the local brew.
That's
another. Then he said he had no treatment for in case his sugar went low.
Yes.
He was not moving with any glucose.
With any emergency glucose, yeah.
So all these issues you can see are from someone who clearly has not had any education in diabetes and how to manage it. Because the truth is, personally, I struggled as well on my journey along the way. Yeah. But eventually, I had to go out and look for that information.
Yes.
So I found substantial books, and these books have completely turned my life around.
Yes.
So I've read, now I completely understand it.
Yeah.
And because I do, I really have no fear anymore. I had a lot of fear before.
Yeah.
I was afraid to wake up in the morning.
Yeah.
I once went unconscious in a bank and lost 2 million shillings. So all these things used to be a cause for fear for me. Yeah. But I've realized after reading all these books and said, you should always have your glucose with you. You should always have your insulin with you. Yes. You should always have your glucometer, a well-stocked glucometer. It's not, if the cost is the problem, we have to find a way around the cost. Initially, costs were a big problem for me. Yeah. So I'd take 1 injection of insulin a day because I was trying to reduce the costs. Yes. So that was first year campus. So I'd take 1 injection of insulin a day, or as opposed to the 3 that I was supposed to take.
You did at least 3.
Yeah. So I'd take 1 and I didn't know what it was doing to me. I just knew, I'm being sharp, I'm being very clever. Yeah. I am helping my life by
and it gives you the temporary feeling that you're okay, yet in the background the blood sugar is above the targets.
Exactly. Yeah. So for a very long time, actually, I was ranging up there.
Yes.
That was basically where I was. I had no energy.
Yes.
I used to wake up in the morning and I could not even get out of bed. And so I cut so many classes in first year. I hope my lecturers are not listening to this.
Yes. So, no, but it's understandable because I'll talk about it later.
Yeah, so I ended up missing a lot because I barely had any energy to do anything. So unfortunately, type 1s, we can sometimes ignore our medication, but we don't know it has effects at the end of the day.
Yes.
So I had zero energy. This is because my blood sugar was always way up there. And you're tired just from having a high blood sugar. You're tired. And people don't understand it.
They don't understand,
because you look normal. You've lost weight, yes, but you don't look sick.
Yes.
So people are like, no, I don't know what your problem is. The moment you get up to walk, your legs can't carry you. They hurt.
Yes.
So people don't see these things. Only you feel them. Your heart is racing because you walked a few meters.
Yes.
So at the end of the day, it's important for people to also understand a little bit more about diabetes because if they do get it, they can offer more support than criticism. I faced a lot of criticism.
Yes.
And of course, that also goes back to the psychosocial health of the patient.
Yes.
Yeah, so it's important to educate the family, educate the friends, educate maybe the significant others.
Yes.
It's very, very important.
So what you raise is very important.
Yeah.
You mentioned at a certain time when things were not good for you.
Yeah.
And then something happened. Something that caused a switch.
Yeah.
Now, I wish you could tell the viewers what is that thing that happened that caused you to have a switch. Then I'll say what I want to say in addition after that.
Is it the hypoglycemia?
No, what made you change your attitude towards the illness?
Oh, it was definitely the knowledge I got from the books. I read a book written by a type 1 diabetic doctor. He was initially an engineer, but he was type 1 and he had all these problems. Because I think in the beginning, there was also very little information in the United States about this thing.
Yes.
So eventually, his wife was he actually paid for his wife to go through medical school.
Yes.
So his wife became a doctor, and using her credentials, he started ordering medical supplies that helped him, be able to test his blood sugar. He managed to get the first glucometers ever made.
Yes.
So in that way, he was able to better understand his disease, and that is when it also started to change for him.
Yeah. So that illustrates very well the issue of activation.
Yeah.
That there's a certain point when a person has a chronic disease, there's a certain combination of issues that enables them to get activated. And once they get activated, they become very optimistic and they take charge.
That's true.
They know the fundamentals and they're ready to work on them.
Yeah.
But information is behind that. Information, experience, getting empowered, and then looking at some role models.
Yeah.
And I was very happy when I got to know about your case, because it is such testimonies that help other people to understand that it is possible. And what we would like to emphasize in the autonomous support is that some of the key people who can spread the message is not the people without diabetes, but the people with diabetes.
The people living with it daily.
People living with it. That's key. They should be empowered to speak, to speak out and show how they've navigated. And once every patient who hits, I call it activation. And we can define it. They get activated and they are ready. You know you have done it. Even when they get a major complication, they'll get down, they will sail through it, and then they will get up ready to and then that will lengthen the appearance of, Now, the other thing I wanted to emphasize with chronic diseases is that in the traditional disease model, we know that you get, let's say, when you are sick, when you have malaria, what happens? What shows you that you have malaria?
Well, the fever.
You get a fever. The patient feels the fever, and then they go to the facility, and then the healthcare worker checks, and they find, it is malaria. Now, in chronic disease, and the fever, in medical language, we call it symptoms, what the patient feels. Then, when the healthcare worker checks you, what they find, we call it signs. Now, in chronic diseases, very often the signs precede the symptoms. The things that the healthcare worker is the one who is trained to detect, they precede for a long time. The blood sugar is high. You're taking one insulin dose. It's, let's say, above 10. You're feeling fairly, but, not very bad. So by the time you feel very bad, you go to the healthcare worker, you already have a complication. So we need to emphasize that for chronic diseases, we should make the detection of signs as easy as possible. In some cases, empower the patients to check themselves.
Indeed. That's true.
Then the other thing which I wanted to say before I forget is that our health system was built to tackle acute diseases. So the healthcare workers have that mindset that someone comes and it's an acute thing. So by the time they suspect a chronic thing, someone has to come several times. We need to break that. Yeah,
that's true. A lot of I've actually had stories where as patients, type 1s have been found collapsed somewhere, and they are rushed to hospital. This is in the United States. But even then, a few of the, if you're lucky and you go to a major hospital, you're lucky you can find someone who actually can see. They know those signs. For example, the ketone breath. They can smell the ketones
very quickly, and they know what to do.
Yes.
And what they need to do is urgent. They need to give a shot of sugar immediately, without even first checking so many other things. So if that thing happened to a type 1 diabetes in our context here, we might lose them.
That's true.
Because the healthcare workers are not trained to be conscious about the possibility of such things. And what we see here is that in treating diabetes patients, we can choose an intensive mode of treatment where our target is to bring down the blood sugars fast, but also maintain them down. Now, in doing that, oftentimes, when we are again so rigorous, we are likely to increase the risk of hypoglycemia, the low blood sugar, and those crises. So that means that the system has to be very supportive to keep checking the blood sugar to ensure that we don't get accidents. And in type 1 diabetes, we see a lot of emergencies actually arising out of
people taking care of themselves,
trying to be very rigorous in taking care of themselves. The other thing which I have to emphasize is that for both type 1 and type 2 diabetes, there's a period of about 1 month when treatment has to be carefully titrated, measured according to the level of the blood sugar. We call it sliding. You keep adding until you reach targets, then sometimes you overreach them, then you go backwards until you find the dose that works. And then the next time is when they get complications, you may need to retune because something happens, they get out of control, and then you have to control them again. Now, here in Uganda, because of the healthcare system is not tuned to that, the diabetes patient will come in, they are initiated on treatment, even insulin, and then they say, come back after 1 month. 1 month is too long for someone who is on insulin. The other thing is some of the patients, transport is a key limiting factor for patients coming to facilities. Not here in Kampala, but in the rural areas. So they will come after a month because they cannot afford the transport to keep coming every week. So that's why we need to take the services to the highest should be a health center 3. Health center 3s, all health center 3s for patients both type 1 and type 2 who are stable. They should get their drug refills and glucose checkups and all that from a health center 3 to reduce the distances.